Oh, and happy Thanksgiving week to all. We're so excited to be here. We got a great team today. My name is Anne Marie Coomfer, and I'm co-discussing with Ravi. And then Magnus is going to be presenting a case, which I know based on past experience is going to be fire, so I'm a little nervous. And then we've got Eugene and Bayan helping out too with scribing and teaching points. So would y'all unmute and say hi? And maybe share if you celebrate Thanksgiving, your favorite Thanksgiving food, and if not, your favorite holiday food.
I'm not sure if you were addressing me. I'm sorry, but
Oh, yeah, no, go for it.
I'm happy to be here. Super excited to present a case. We don't actually have Thanksgiving in Denmark, so it's soon Christmas, so that's kind of the same for us, I think.
Do you have a favorite Christmas or holiday food?
Yeah, just like we normally eat roasted duck for dinner. That's one of my favorites. I love that.
Ooh, that sounds delicious. Eugene, do you want to unmute and say hi?
Hi, everybody. I'll be doing teaching points. I'm Eugene from Ghana. Very excited for Dr. Ravi and Ann Marie's case.
What's your favorite holiday food?
Um, I don't think I really have a favorite holy food, but my favorite food is actually what we call jollof rice. So it's a mixture of jollof in tomato sauce. That's rice in tomato sauce, and then you make this whole food called jollof. Yeah, and
I think
it's
I've had
this
jollof rice before, and it was delicious.
nice. Yeah. So it's basically my favorite food. So whether holidays or non-holidays, that's what I'll go for. Yeah.
Oh,
We don't
just jump
we don't
jump
need a
in.
holiday excuse to eat good food.
Dr. Ravi, don't tell me you've had jollof before.
No, I was gonna say something boring. I love mashed potatoes. I don't know why,
Uh,
but good
What
mashed potatoes.
controversy. I think Eugene Bayon's on your side. So what's your favorite holiday food?
Hi everyone, my name is Van. I'm a medical intern from Syria. Um, in the spirit of autumn season, I love anything with cinnamon, so a good cinnamon roll.
Ooh, that sounds delicious. I'm all about the carbs. I love anything with carbs in it. Awesome. So with that, I think we can get rolling on the case.
Great. For the first aliquot, we have an 88-year-old woman who presents due to chest pain and shortness of breath for 5 hours. And I'm gonna stop there.
Okay, Anne Marie, since you're the guest, do you want to take first dibs on this?
Oh, sure, sure. So I think that this is a space that's very well known to us, where, we have these like great schemas to help us think through and work through chest pain. And, I think the thing that we're really going to want to be triaging and thinking about is, is this some sort of emergency? So, like thinking about the things that we don't want to miss that's, well known to us, like an acute heart failure, an aortic dissection, a Takotsubo, ACS, pulmonary embolism. So we're going to like definitely be thinking about all those things, and additionally infection as well. And I think we'll have to think about kind of how the shortness of breath changes our differential. The heart and lungs work really closely together. And so there are kind of a lot of causes of chest pain can also cause shortness of breath. But just depending on more kind of characteristics of how it's described, it, might kind of make me go more towards one system or the other, but those two can oftentimes kind of interact with each other and how kind of because they're so married together. And so getting more information would definitely be helpful. And then kind of knowing who this patient was, what history they have. And because they're elderly, I'm really going to be kind of keeping everything on the table for as far as causes. Like it really could be the whole spectrum of disease. Ravi, what do you do with this information and how do you sort it out?
But yeah, absolutely wonderful introduction there, Anne Marie. I think I'm thinking along the same lines. And as hospitalists, we do see this. We commonly do get a call from the emergency room that somebody is coming in with chest pain plus shortness of breath. So I kind of also see which one is the most predominating cause because there's some conditions that could be, like you said, the heart and lungs are one unit when they function together. Is this a primary pulmonary issue or is this a cardiac issue primarily? But the first thing right off the top of my mind is to immediately reach for management reasoning, which is what is the best test in an elderly patient. And the pre-test probability for disease or cardiac cause of disease in an 88-year-old versus a younger, somebody less than 50-year-old, would be atherosclerotic heart disease. And could it be ACS or could it be chronic stable angina? We don't know. But I think, first of all, rule out myocardial infarction, get an EKG, get troponins, and then if those tests are negative, is there risk? So in the past medical history, we're going to look for certain risk factors and also typical atypical features of coronary artery disease or its presenting complaint of myocardial infarction. So those things I would worry about. There's all these other causes too, which could be atypical. I remember once I had a patient with chest pain and we got all deeply concerned about coronary artery disease and so on, and end up just being shingles of the chest. So yes, that's less likely, but do a primary surveillance when you do your exam. But everybody should at least get those tests because you don't want to miss an active MI and then get the patient up to the cath lab in a timely manner and also do initiate all those life-saving treatments necessary, like aspirin and so on, IV heparin and so on. So blood thinners, antiplatelets, and so on. But at this point, I think I'm hunting for more information because I have no idea what's in store for us. Something
Yeah.
I always kid about Magnus. Magnus, one of my favorite Shakespearean plays is Hamlet, and in Hamlet they say something is rotten in the state of Denmark. So live and direct from Denmark comes this case, courtesy of Magnus. Over to you, Magnus.
Yeah. Oh, and I guess, sorry, the only other thing I'd say is I think the vital signs will be really helpful in like quickly triaging because if the patient is super hypotensive or hypertensive or like their, oxygen levels are low, we're gonna have to like really stabilize, think through like versus if everything looks stable, that's gonna kind of change our kind of differential and also how quickly we have time to get things done.
Amazing. So we'll figure out whether something is rotten or not. So for the HPI, it actually began 5 hours ago when she experienced sudden onset central chest pain, and she actually went to bed after that and fell asleep. But she woke up 2 hours later with a severe shortness of breath, which has been constant over the last 3 hours. She also still has chest pain, which is rated a 5 out of 10 in severity, with no radiation. And on reviewer systems, she had no cough or fever, no nausea, vomiting, and in general, no other symptoms apart of these. For her past medical history, she has CAD with a prior PCI about 15 years ago. She also has heart failure with mildly reduced ejection fraction. So her last echocardiography showed an EF of 50%. She also has hypertension, osteoporosis, scoliosis, a total knee replacement, and then she's currently undergoing evaluation for dementia. And in terms of her medications, she's on aspirin, verapamil, furosemide, calcium, and vitamin D. She is a retired school teacher and currently lives in a nursing home. And normally she uses a cane and a walker. She does not smoke or drink alcohol, and she has no allergies. and her family history is not significant. So I'm gonna stop there.
Okay, wonderful. So Magnus has set the stage with this tremendous past medical history, and we were hypothesizing, is there something in the history that will help us springboard to the concerning diagnosis? So what really is life-threatening here? You take coronary artery disease, PCI, HEF, MF, may not have as much bearing, but we know this patient suffered some cardiac insufficiency because of ischemic heart disease. But just coronary artery disease and previous PCI just yells right off this stage that there's likely an acute exacerbation of this, an acute version of this. So why not? Then comes all the other things that you could think about, the prothrombotic risk, this sudden onset. And it looks like there was a sudden onset, but then it's just going on for 5 hours. So then you kind of dive deep into the causes of chest pain and how do they usually have characteristics. So acute like aortic dissection suddenly will come on and then it will kind of go into a lull as the tear happens. It's not going to just linger on maybe for hours, although there can be atypical presentations. ACS, again, 5 hours, this pain is just continuing on. And I guess the patient's not really doing anything. It's not coming and going, but you can have this. But I would wonder if it was an impactful episode of chest pain. 5 hours, the patient really would decompensate. Same thing with PE, tension pneumothorax or pneumothorax. Patient would not just sit there for 5 hours and not get worse. But this progression to shortness of breath, again, the heart probably is at the center. So how would you push or move the diagnostic needle forward? Testing would be really helpful. But again, we have to put some weight on the exam. What could the exam show us? A lot of what medicine is anticipation. You have the complaint and you prove your initial hypothesis by doing testing. And ultimately, if the exam yields, say you listen to the lungs and there's a decrease in breath sounds on one side, maybe as a pneumothorax, as there is asymmetry between the both sides of the chest, it could be pneumothorax. So things like that. PE, is there a swollen leg? Maybe that may indicate that there could have been a thrombus in the leg. So you're going to be hunting for clues. And Anne Marie had mentioned the vital signs. Vital signs will be very helpful in this to see if there's hemodynamic instability. Anything else comes to mind, Anne Marie?
No, I think that was a great evaluation. I think that, like in patients, especially with past medical history, I find it very helpful to review the medication list because I think we have to consider, in addition to their past medical history, what are the effects of the meds that they're on? And how could that, or in some cases, could that like precipitate further issues? Like if someone's on anticoagulation, thinking about like bleeding, and then it being supply demand mismatch, or if someone has just received a course of doxycycline, thinking about, could there be a pill-induced esophagitis? Obviously, you need to rule out the life-threatening things first, but you can often get a lot of information from the medical history. And then you can also sometimes like kind of hypothesize, generate, like she's on verapamil, and like be like, why is she on verapamil? Does she have this like history of AFib that we just haven't been told about? Like, or is there something, that we're kind of like missing about why she's on that med? Or sometimes people just were started on the med a long time ago and continue on it. But I do think that there's, helpful information that we can glean from that. So here I'm definitely like Ravi, really thinking primarily about the heart and then how the heart is interacting with the lungs. So knowing that there's a history of CAD, first and foremost, I'm going to be thinking about, is this a problem with the coronary arteries, either because there's a primary event in it that's going to be first and foremost in my mind, or that there's another stressors that are unmasking, coronary artery disease and that supply demand mismatch that could be going on. And then thinking about, other things that could affect a heart that's been under stress, like an arrhythmia, AFib, things like that. And then thinking about, like what's the volume state, what's going on in the heart. I think that a good physical exam is going to give us a lot of information, and then a few key labs to kind of help us know like which part to delve into here, because it really is a wide open differential here.
Yeah, Marie, just one quick thought looking at so this HEF-MEF, right? Uh, Treatment, pretty much what I remember. Although there may have been a change with this classification of cardiomyopathy or improved cardiomyopathy. Like treatment usually is you continue on the usual guideline directed medical therapy. So the pillars of HEF-REF, I think, are usually employed with RAS modulation, beta blockers. I don't see any of that here, but kind of unusual. I don't know. Maybe in Denmark, there has been certain literature now, it says that may mention that we do not have to employ these meds since there is an improvement in the EF. But just a thought, maybe you're missing these meds. Any other thoughts, Anne Marie, before we move on?
No, I think at this point I just want to get some more data.
All right. Ask and you shall receive. In terms of her medication, I'm not sure why she was not on regular heart failure medication. I'm not entirely sure whether that was like taken from her, whether she had been on that before, or whether she was never started. But in terms of her physical exam, she was afebrile with a blood pressure of 195 over 94. Her heart rate was 92 and a respiratory rate of 24. Her oxygen saturation was 85%, but improved to 95 with the 2 liters of nasal cannula. And in general, she was quite tachypnic, but did improve with oxygen and was breathing comfortably after that. There was no JVD appreciated on exam, and the heart rate heart exam was notable for irregular rhythm, but no murmurs that I could hear. In terms of her lung exam, she had bilateral breath sounds with bilateral crackles, predominantly in the lower lung fields. Her abdomen was soft and non-tender, and there were no peripheral edema, and she had pulses in all 4 extremities. I'm just gonna stop there for a moment, see what thoughts you have with that physical exam.
Yeah, so I think it's definitely helping us kind of hone in on what could be going on here. Definitely, I'm worried about the tachypnea and the low oxygen levels. It definitely makes me think that there is something on kind of the interface of the lungs and how it's exchanging oxygen, like just things like anemia. You shouldn't get low O2 sat. So I'm thinking about there's like some process there that is affecting the oxygen exchange at the level of the alveoli. And, like when that's the case, you're thinking about, is this fluid? Is this like pulmonary edema? Is this pus? Is this blood? Is this, some other substance that could be at play here? And so really trying to have an kind of a hypothesis driven physical exam to help me get to the bottom of this. I think in the hospital, oftentimes we see patients who are very hypertensive for various reasons. And there's definitely been a shift lately of kind of rethinking hypertension in the hospital and everything. And like, thinking about like, are they truly like symptomatic or are they asymptomatic, and about how to triage. But in this patient, I'm very concerned about the hypertension, because I'm concerned that while it could be an innocent bystander, that this could also be something that precipitated this decompensation event. So, if she's very hypertensive, her heart is squeezing a little bit more weakly than normal. This could precipitate like a flash pulmonary edema, which is something I always want to remember, or just like worsening heart failure with time if the hypertension has been very long standing. So I'm going to want to like really pay attention and think like, do I need to more urgently lower this blood pressure? Like, what do we need to control the blood pressure, and how much is the blood pressure the driver behind this presentation, or is it more that like because of anxiety and difficult breathing that it's more of an innocent, bystander here? But I'm going to kind of be more leaning towards it may be causing the pathophysiology until kind of proven otherwise. And so kind of with the exam, hearing crackles in the lungs, I'm still thinking about all the things that I talked about. Like definitely my number one concern is like fluid. Because especially with bilateral crackles, that's what we know. Of course, there's a lot of things that can cause crackles in the lungs, that we've learned. You can get it from ILD with those like kind of fine Rice Krispie type crackles. Like oftentimes you'll see it with just like bad atelectasis. So like you get kind of bibasilar crackles. You can see it in pneumonia, like a viral pneumonia that's more diffuse. So you definitely don't want to say crackles and immediately assume without kind of looking for other data that this is pulmodema. But here with kind of the exam and everything that we're given, that's like my number one concern. The no JVP is interesting because I'm like very concerned about the volume overloaded state. I will say that the JVP exam can definitely be like fraught with difficulty. And so sometimes it's just hard to visualize. And we say no JVP because we can't see it well, just because of the neck or how it interacts. And so sometimes gathering more information, like by ultrasound exam and other information, can help with this. Or sometimes you can be in a state where it's not a problem with too much volume, it's a problem with kind of pressures causing rapid shifts in volume. And so that can be at play as well. Ravi, and then I'll let Ravi talk about the irregular heart rate and then other thoughts that he has.
Yeah, Anne Marie, it was really nice to hear you go through this. You picked up on the points I was kind of thinking about as well. So that I think we're sort of approaching the same or similar cause or hypothesis or suspicion for condition. Yeah, I was thinking like JVP. JVP has such a high likelihood ratio for heart failure. This is screaming heart failure, but it doesn't appear the patient has the setup for heart failure, right? They have HEF, MRAF, so mildly reduced, so not majorly reduced where any excess of volume, salt, and they haven't been on medication. They've been on furosemide, but we don't have the key medication to shut down the RAS system. So the RAS system is always in overdrive. As soon as you remove fluid via the urinary system, the RAS is always thinking, yeah, there's all this excess volume outside of the vessels, so we're in a low flow state, and so the kidneys will rev up and absorb more and more sodium. So the mechanism likely here is probably not volume overload. They appear to have euvolemia. I'm kind of brazen to say this, but there's no peripheral edema, there's no JVP. The blood pressure is interesting. So the blood pressure, is it a signal of volume overload? And like you had rightly mentioned, volume overload, increased afterload, and the pressure backs up and causes flash pulmonary edema. Or is the blood pressure, so volume causing high blood pressure and increased afterload, or is the high blood pressure causing something called SCAPE? So you have the sympathetic surge, you have the congestion and pulmonary edema that may happen. Interestingly, I'm going to go and do sim lab and have a SCAPE sim session. So I usually run that with the residents in that case. So with SCAPE, you don't actually have the signs of um, the conditions or the exam findings that have a high likelihood ratio, like JVP, like peripheral edema, like hepatojugular reflex, and it can be associated with normal volume as well. So maybe the blood pressure is causing this downstream effect or backward effect on the heart and causing decompensation like we're seeing. Because usually the story is with heart failure, you congest slowly and build up. So it's sort of a ramp up, and then you present with all the features, orthopnea, PND, very high likely ratios for heart failure. We're not having this narrative here. This patient had non-radiating chest pain. That's another condition we really didn't incorporate into this. Why is this patient having chest pain? Have you ever seen, Emery, you ever had patients with uncontrolled high blood pressure? So we talked about patients with blood pressure, if they're asymptomatic, we don't give them IV hydralazine and so on. So you brought up an important point there. But I've had patients with blood pressure, high blood pressure to this degree come with this sensation of pain in the chest. Have you had that in a patient before? You noticed that?
Yeah, no, and I certainly think that I mean, I think my number one concern is that either that the blood pressure is driving this or that the blood pressure is, a secondary effect of the underlying process. And then so we need to figure out, make sure we're not missing like a aortic dissection or something like that. But yeah, I think certainly, especially when you have kind of a sick heart, like if you think again about the supply demand mismatch, like the increased pressure that like the heart is trying to, squeeze and then like diastolic times, it makes sense that you could have some chest pain like when your heart gets so high. So I think there's a lot of things, here. Like, of course, we don't want to miss an ACS or we don't want to assume that, but I think it could be that the blood pressure is driving this or that there's a secondary process that's driving kind of all these things together and sympathetic surge.
Absolutely. What I said in 20 minutes, Emery just said in 5 minutes. So kudos. Over to you, Magnus.
Amazing discussion. In terms of her CBC, she had a normal hemoglobin at 14.5. Leukocytes were 10.7 with neutrophils at 8.9. Platelets were normal at 289. Sodium was also normal at 140. Potassium slightly low at 3.3. Creatinine was 1.0, which was at her baseline. Her LFTs were normal. Her LDH was elevated at 300, and her trope was elevated at 69, normal being less than 15. And then we obtained an EKG, which I will share. Oh, can you make me co-host, Ravi? Sorry. Yes.
Oh, thank you, Magnus, for bringing this EKG. So, yeah, Anne-Marie, I didn't comment on the irregularity here in this case. So, irregularity, you can see why there's this irregular rhythm here. So, I kind of will start off with the rhythm strip at the bottom and see, can I see P waves? And I do see P waves. And then I see an extra ventricular beat. So, there's a PVC. So, there are random PVCs. And then there's a PVC with a different configuration. So there's two different PVCs, but it is sinus rhythm. We do see P wave. I don't see thinking about irregular rhythms, one of the most common irregular rhythms. So what could throw you into pulmonary edema is atrial fibrillation, especially if you have RVR. But is there anything else? So with frequent PVCs, now, the only thing about PVCs, if you do have frequent PVCs, if they're like more than 10,000 within 24 hours or more than 50% of your strip or EKG, you could develop a PVC-induced cardiomyopathy. So maybe what if this patient is having frequent PVCs and having a cardiomyopathy due to that? So the next thing you want to do, and what can be tested on our ABIM exam, is do an echo. They usually want an echo if this question does come up. Um, any other findings here? No. Otherwise, we see V1, V2, V3. See the R wave progression, if you just look at the background normal rhythm, the R wave progression is pretty poor. Yeah. So it's kind of late. And let's see. No LVH I can see here. No bundle branch blocks. Yeah, I think that pretty much. Anything you see, Emery, on this EKG?
No, I agree with what you said. I think we can see P waves and they're, upright in two. They look, like a regular morphology. So we're thinking that this is, probably coming from the sinus node, which is good to know because we had the question with the irregularity. And then I think the PVCs, I do think there's no rhythm strict at the bottom. So the different morphologies I think are just
Oh, right.
versus V6, which I did not realize at first either. And I was like, why did the morphology of the, QRS change? So I think that is why. But I was also just looking for like any changes in like 2, 3, um, looking for like any inferior changes and didn't, see obvious or, obvious like acute um ST changes or like hyperacute T wave. So I don't see like obvious signs that makes me think of like, ACS or anything like that.
Absolutely. Yeah, there's no what we call current of injury here. What's interesting when you do see an EKG like that, but the troponin is elevated.
Yeah.
So in this case, is this unstable angina? It hasn't become, using that term, OMI, has it is not become, or what's the old term we used to use, non-ST elevation MI. So are we heading in that direction, or is just the blood pressure and its retrograde effect on the wall of the myocardium causing that little release of troponin there? And you can't always just use one troponin. You need to do a set of troponins, see what the trend is. So like one troponin in the span of this case here, it's really not going to help you. It's going to put your antennas up, but it's not going to tell you if it's flat. So we have certain trends, right? You have a quick spike up and down, so there could have been trauma or injury. There could be a relatively elevated and a flat, which could be due to increase what Emery had mentioned, increased cardiac demand due to maybe hypoxemia, due to maybe hypotension, due to tachycardia, so certain things. But then this trend that continues up to a certain peak could be acute myocardial injury. So the trend will be kind of helpful to see if coronary artery disease is behind this case of this patient.
Mhm.
Any other thoughts before we turn the mic back to Magnus?
So I think there was a few thoughts on the labs. So yeah, the troponin is just a little elevated, and so I think there kind of more time, but this could be more of an effect of the heart being under increased stress from the hypertension. But we would definitely want to make sure we're not missing an ACS or another event. Um, and then the potassium being just slightly low is something that I'm just putting an asterisk by in my mind because sometimes like certain causes of hypertension and secondary hypertension can cause low potassium. Like certainly there's other reasons, but just thinking about your aldo and renin mediated processes that could be at play here. Um, and then like the excess cortisol state too. So kind of just thinking about that and seeing, if there's been hypertension for a while, has a secondary workup ever been sent? So I think here I'm going to be thinking about stabilization. Like, what do I need to do for this patient right now to get her breathing more comfortably, to get her blood pressure in a safer range? And then thinking about more like long term, like what precipitated this event? Like, what is the cause versus effect? And thinking about like with the hypertension, like it seems like there's this, sympathetic drive, but why is she so hypertensive, and like really trying to understand and explore that space to try to help prevent this event from happening again.
It absolutely, yeah. I with the troponin, I think, yeah, you're right. It's a mildly elevated, but again, the trend will help. The good point. I really like the point. You know, what's interesting. Recently we had a spate of we had a case with pheochromocytoma, sympathetic overdrive or exacerbation due to pheochromocytoma, and there was another case I think recently where it was hyper-con syndrome or hyperaldosteronism. So that's always key when you have these labs. The LDH, it's there in red, it's mildly elevated. I was trying to see, is this a signal we can latch onto and maybe make progress in this case. So usually LDH, this isn't significantly elevated. So hemolysis usually is my first sweep of LDH, causes of LDH. Second line, it would be organ injury. So LDH is usually not just expressed. It's not like something you just, it will just be um, deep let out into the blood. It's usually intracellular, and if there's injury, it will be expressed in the blood, just like troponin. So could this be from injury to an organ, the lung, if there's pneumonia, maybe if there's pulmonary edema, the lung can express it, the heart can express it, and the liver can express it, the kidney can express it. So you have many different organs where it can be expressed. And then comes lymphomas, vasculitis, leukemias. So lymphoma, we always have LDH. We always tend to associate LDH with the lymphomas. But here, again, if we think about solid organs, maybe this is leaking out just like the troponin from the heart. All right. Any other thoughts before we swing the mic back to Magnus?
No, I mean, I'm definitely curious. I think the echo is really going to help guide our next steps and where to go. I mean, this is a patient I'd be worried enough that I probably would be talking about to cardiology regardless, trying to get like a very expedited echo, doing a bedside POCUS just to help guide next steps while probably giving her a slug of IV Lasix, considering an antihypertensive medication too. If she remains hypertensive. And of course, if we're concerned about flash pulmonary edema, oftentimes we'll like start them on a drip while we're stabilizing them.
Wonderful. So we will continue with the APG that showed an pH of 7.44 with a PO2 that was low at 53, a PCO2 of 29, which was also low, bicarb of 19, and a normal lactate at 1.1. We also obtained a D-dimer that was elevated at 13, normal being less than 0.9. And then we had a chest X-ray, bedside chest X-ray, which I will try to share. So I will just here. And I'm gonna stop there.
Ann Marie, you want to take first discussion on this?
Yeah. So some of the things that, I'm watching out and noticing her are the heart looks big to me. It does sound like it's maybe a portable X-ray. And so sometimes that can be a little bit off in dimensions, but it definitely looks like a big heart. And then I'm also looking at the mediastinum, just um, the mediastinum may be a little bit on the wide side as well here. And then looking at, it looks like maybe on the right side there could be a small pleural effusion. It looks pretty small. There's some blunting of the diaphragmatic angle. And then a little bit of just like general haziness in the lungs. It just kind of looks hazy throughout, but it also looks like it's maybe not the best inspiratory effort, which can happen if the patient is tachypnic and it's like a bedside one at the bedside. Um, so definitely things that I'm thinking about. And then I'd also be curious if like the blood pressure was checked in both arms and equal, just because don't want to miss like an aortic dissection, things like that. Ravi, what are you seeing here?
Yeah, I think I'm probably seeing some things I'm not kind of putting a lot of weight on it. That aortic knob is a kind of prominent. And you see the trachea, the patient is maybe rotated a bit, so the trachea is deviated a bit. So is there something there? The left main stem bronchus is sitting right on top of the heart. So the heart may be enlarged. Like you mentioned, this is large, so it may be pushed up a bit. And then between the aorta and the heart, it's a little full there. I don't know what that is there. Could this be, you have this D dimer that's elevated, and you, even though I am less suspicious of PE, you still have to do your due diligence, maybe get a CTPE and also then look in that space there. So could there be something brewing in that area? Other than that, I'm not really seeing anything else. On the left there, there's a little shadowy sort of a shadowy area, which could be just um, skin fold, but you don't see it on the other side. But there is a little opacification towards the periphery, and this has a triangular complex. Yeah, it's probably artifact. But yeah, I'm not seeing anything else. I'm not seeing, so like the penetration is not that great, so I'm not seeing the aorta going down. So say you're thinking aortic dissection, widen mediastinum. We're not seeing that sort of configuration. But if that was there, that would obviously help us and give us at least something to follow. But I think, yeah, I think that pretty much would be my guess with this X-ray. Magnus, what was the official read of the X-ray?
Yeah, so the official read was as you said, enlarged heart, and there was also signs of pulmonary congestion, maybe a little effusion on the right side. And actually, the next Alcott is going to reveal the final diagnosis. So I'm curious if you have any final thoughts.
Hmm. I think at least with testing, I wonder if a CT is done. Echo, like Anne-Marie mentioned, kind of would be helpful. And we have POCUS nowadays, which could help to see at least on if we do the four views, one view is no view. So I would at least do the parasternal long axis, short axis, long axis, look for the left ventricular wall excursion, the anterior mitral valve leaflet if it's hitting the septum, indicating good EF. If the walls of the left ventricle are properly approximated, properly sized or thin. Those three findings usually, if you have thin wall, poor myocardial wall excursion, and poor kick in that anterior mitral valve leaflet, that could indicate cardiomyopathy, moderate, mild, severe cardiomyopathy. And then looking at the parasternal short axis, look for right ventricular overload. Here, I'm not really seeing right ventricle. Sometimes you could see the right ventricle enlargement, but that would be something to look for. What who was it who mentioned the donut and croissant sign? So the croissant becomes like a donut, loses that configuration, and then you get the septum pushed into the left ventricle, causing the D sign. So you would look for something like that. And the other thing would be like pericardial effusion. Here again, the heart is enlarged, but I don't suspect pericarditis, pericardial effusion. What do you think, MK? Any other tests you think that would get this one diagnosis?
So I think in real life, I would not be making a diagnosis right now. I'd be like still gathering the information and trying to figure out what's going on. So I think like there's a part of this that's like a little bit kind of artificial. So I agree with you. Like I think if it was a big pericardial effusion, certainly they can happen in volume overload, but obviously if it was causing like tamponade physiology, we'd expect hypotension. So that doesn't seem to be the primary case here. The D dimer is a different reference than what we use. I think if we calculated from that an age adjusted D dimer, it'd probably be a little bit high, but not crazy high. But I am like kind of inferring from different units than I normally use. So I think a lot of my like next cognitive energy would be looking at the heart itself and looking at its squeeze. And some of the things I'd be thinking about is, has this hypertension been going on a long time and then caused a, hypertension induced cardiomyopathy, low EF related to that? Or could there be like this sympathetic surge causing a Takotsubo like picture? Or do we see wall motion abnormalities that would be concerning for a primary cardiac event? Or, do we see that like really significant right-sided enlargement as you talked about that would be concerning for like a PE or some sort of primary right-sided etiology. I definitely think we will have to be like thinking to ourselves, like, do we need to absolve a PE right here? And I think it's definitely like a hard situation, like in kind of like that moment to decide. But I also think it's okay to like take a moment, do a POCUS, kind of see how things like resolve with like treating the pulmonary congestion, see like and bringing the blood pressure down, see how the breathing is resolving, and then kind of making a final decision based on like if you see like kind of what further data that you see. And especially if she's not stable, you're not going to want to wheel her down to a CTA immediately where you have to lie flat. So I do think it's okay. Like we obviously don't want to miss it, but since there's could be a lot of other stuff going on, I think it's okay to take a moment, catch your breath, gather some information, and then make a, kind of final decision about if you need to look for a PE, kind of when you have a little bit more kind of diagnostic momentum and everything.
One thing I would add, I think, it's now ruling out life-threatening causes. That would be one. A lot of times, if you get cardiology involved, they will ask, like, can you rule this out before we maybe do a cath in this patient? But I would get another set of troponins and repeat an EKG. I don't know if you had this kind of situation where you do sequential EKGs and eventually a STEMI shows up because there's a STEMI in evolution and troponins rising and rising. So I had a patient like this where I did the third set of enzymes started climbing up, and then the third or fourth EKG showed ST elevation with ongoing chest pain. Like this patient's had a chest pain for 5 hours. This patient had chest pain for 2 hours, and we just continued while doing the workup. So, all right, Magnus, over to you.
Amazing discussion. And yeah, because this was at quite a small hospital during nighttime, and we have no cardiologists that work at night, and my POCUS skills are not the best in the world. We proceeded with a CTA, which I'm gonna share. So we'll see here. So her CT angiography showed bilateral pulmonary emboli, and I'm really not a radiologist, but I think what we see here, like these gray areas on both sides, are pulmonary emboli, and then so with her other symptoms, we interpreted this as bilateral pulmonary emboli together with decompensated heart failure. She had an echo done, of course, I think the next day, which revealed actually not like severe right heart strain, which was probably also in line with the no JVD or edema on exam. She did have like a reduced ejection fraction from prior, so it was down to like 40% or so. But she was managed, yeah, with oxygen and Lasix and low molecular heparin, and she actually did quite well. So she was discharged, I think, a week afterwards, and yeah, I checked up on her a few months after, and she was actually doing well at that time. I'm curious if you have any thoughts on the case, or yeah, in terms of management or anything like that.
This is quite a case. I think what was interesting is we always think about PE on a continuum, and this patient, especially with the sympathetic, we use the term sympathetic overdrive or excessive discharge. Yeah, this patient was stressed to the point, stress does funny things to people, and this stress was causing this blood pressure. Well, does her blood pressure go up this high, or it was just this presentation, it surged? Because some patients have chronically elevated blood pressure.
It fell down afterwards. I think it was primarily the pain and her dyspnea that led to sympathetic excess at that time.
Yeah, so it's interesting, Anne-Marie. We always think about large PEs and decompensation. So it was just a matter of time, I think, if this wasn't discovered. this patient, then you would see that decline of that blood pressure into the hypertensive states. And at that point, this patient is in very serious trouble at that point. So physiology can do interesting things, especially 88 years old. The physiology is so robust to have this surge. The pain was tremendous, and the blood pressure just shot up. And it's interesting how much weight sometimes we put on this. But in retrospect, I think, yeah, I've seen so many variations of PE. It's just, I've had patients come with just shortness of breath, no chest pain, just shortness of breath, mild, and they're sitting on a large PE. I had a patient with just minimal hypotension, nothing else, no chest pain, no shortness of breath, blood pressure just a little low, and a fever, and had massive PE. So when you learn the normal from textbooks, you then have to apply that to the abnormal. And P is one of those things is very sneaky. And I've been blindsided by it multiple times. So really appreciate you bringing this. Any reflections, Anne Marie?
Just that I'm constantly humbled by PE and like what it can do. And I think the hardest thing is like when it could like plausibly be so many different diagnoses. And sometimes it is like, that the PE is going to like kind of, cause a decompensation and sympathetic drive that probably like decompensated her heart a little bit as well. So it's definitely a humbling diagnosis, but I always love hearing the different presentations so that, I make sure to kind of like continue to remind myself of kind of all the ways that it can present and kind of all that stuff.
Wonderful. Thank you, Anne-Marie, for discussing, and Magnus, such a wonderful presentation, so skillfully presented. It's such an important case because this could help patients. Your case may help me manage a patient tomorrow that comes in with PE like this. So I will think of Magnus and send you positive vibes in that case as well, transmitting positive vibes to Denmark. Over
Thank you, Ravi.
to
And I also just want to say
sure,
thank
sure.
you so much. And I think it's amazing, even though this is like bread and butter medicine. I think the amount of differential diagnosis that you were able to mention is just it's just fascinating to listen to. And I wish you were there with me at the time, but it's not really appreciate to present it to you here.
Yeah, and if you ever come stateside, I'll be happy to teach you some POCUS anytime. Um, and thank you, Anne-Marie, for coming on and discussing. This was very insightful, the massive amount of teaching points that you just shared with everybody. And we'll send the mic over to Eugene for the teaching points.
Hello, can you hear me?
Yes, we can hear you.
Sorry, I'm just having some connection problems. So this was an elderly female who presented with acute chest pain and shortness of breath. And for CP solvers, we've had this presentation quite often. And usually it's a broad array of things that can cause chest pain, broad array of things that can cause shortness of breath. But when you put those two symptoms together, you do not want to miss a cardiac cause. So you try to place a cardiac cause at the center whilst you're thinking around other possibilities. So Dr. Ravi mentioned about the anatomic approach where you could think about the heart itself, the vessels around the heart, the lungs, even the skin as well, being a cause of or precipitation of chest pain. Then we talked about the duration, which was just within 5 hours. That sparks the thoughts of emergent causes. So typically when you have chest pain and shortness of breath within a very short period, very acute, you're thinking about acute coronary syndrome, or you could think about a pulmonary embolism, or you could even think about pneumothorax. Ravi mentioned that if there is some bilateral, so if there's some form of asymmetry with the chest pain, so there's bilateral chest pain, you could think about probably spontaneous pneumothorax. And We also talked about valvular pathologies like aortic stenosis causing chest pain and shortness of breath. And then we talked about some lung pathologies like pneumonia, which can actually also cause, but that usually presents in subacute, sometimes in a chronic state. Then we got to know that this patient was very vulnerable already and had previous coronary artery disease and had a stent placed and already had some heart failure with moderate reduced ejection fraction and then hypertension. So we centered more on the cardiac causes. We were trying to understand why this patient was already not already on some medications that could protect them from the RAS system causing decompensation. So Ravi mentioned that these patients have an absence of some medications that control the RAS system. So for instance, the ARBs and then the ACE inhibitors makes them vulnerable already for decompensation. And we were able to understand that the patient didn't have a volume problem, but had a sympathetic state, and that was through the vitals. So we're trying to understand why the BPs were high. So was it as a consequence of the underlying problem, i.e. the heart is trying to pump blood into areas, I mean, it's struggling to just pump blood into areas to perfuse organs, or could it be that the hypertension is what is driving the syndrome that we're seeing? That is, with that increased hypertension, you could have what we call flash pulmonary edema, which the other vitals pointed out and also the examination findings pointed out too. So this patient had a wet lung, had tachypnea and hypoxia. So we were thinking around that, and that's what we were trying to identify areas in the labs and then also imaging that could guide us to understand, is it from cause or consequence? So picking out a bit of the labs, we got to know some of the causes of high LDH, starting from hemolysis. And then also we got to know that if there's injury to certain organs, I mean, usually the solid organs, if there's injury to them, we also have LDH spill up in the blood. And we talked about lymphoma also causing that. But these were just guiding us along differentials of increased LDH. We also talked about the level of troponin not really pointing to ACS unless we saw an increasing trend over time. Then we mentioned about the D-dimers. We're not sure if it was very elevated or just because this particular lab value with the less than 0.9 was not something that is the usual. So is it very elevated or not? But we still talk about if D-dimers are elevated, then we could be thinking about a pulmonary embolism, which was one of our thought process in the beginning when we got to know this patient had chest pain and shortness of breath. So the latter point was that we needed data to understand why the chest X-ray presented with an enlarged heart and pulmonary congestion. We had to do the echo and CT because an enlarged heart with congestion could mean multiple things. The enlarged heart itself could be as a result of fluid around the pericardium, but if it was causing tamponade, we could have seen that in the vitals where there would have been hypertension. The enlarged heart itself, typically the right side enlarged, could be as a result of strain and then backup of blood, causing the lungs to be wet. A typical thing that will cause strain is the pulmonary embolism. So we thought about doing CTP and then also doing echo. So echo to help us rule out cardiomyopathies or congested heart failure, and CTP getting us the emboli. And indeed, when we did those labs, we realized this patient had bilateral pulmonary embolism and an acute decompensated heart failure. So that brought us to the end of this wonderful case, which was packed with a lot of physiology and then how the vulnerable state can precipitate to a decompensated state. And also one of the typical ways in which a pulmonary embolism itself can also lead to acute decompensated heart failure. So that's why I'll put my teaching points. Thank you.
Thank you, Eugene. Very encompass or very what do you say? Very, very detailed teaching points. And again, I'm thankful in the spirit of Thanksgiving, thankful to my colleague Anne Marie for coming on and discussing after interviews. And Magnus, again, wonderful case, fantastic management of this patient, and Bayan and Eugene for helping with the teaching points and scribing. Have a wonderful Tuesday, everybody. Have a wonderful holiday. Happy Thanksgiving to you, Emery, as well. And hope to see everybody back tomorrow for VMR. Take care. Have a good day.